Perfetto.
Così è aperto il microfono anche.
Okay. Emanuele, should we start? So welcome to Brain Monitoring Part 2. I will ask the same question that Linda De Vries asked you. How many of you are using EEG, conventional EEG? Some, which is excellent. So some of my slides will be repeating because Linda told almost everything, but some not. But the main issue is the same. So why should we monitor in the intensive care unit? We monitor the vital sign. You monitor as a neonatologist the vital sign, and then what do you do if there is a drop of the heart rate or if there is a drop of the saturation? Then you take immediate actions to take care of that. But if we concede that the brain function is as worthy of monitoring as heart, lungs, or kidney, then we should provide the same standard of monitoring for neurological management in the neonatal intensive care unit. And this was the topic of a very nice review in Nature earlier last year that Donna Ferriero wrote, and exactly talking about that, talking about neonatologists. She was saying they monitor pulse, temperature, and heart rate, but in most cases the brain, which runs it all, is being completely ignored. So we have several challenges. We have the challenge of seizure recognition, we have the challenge of using the correct terminology, and we have the challenge of the right diagnosis. And I will go through this with this presentation and my presentation tomorrow on seizure and epilepsy syndromes. Why is it difficult to recognize seizures in the neonates? First of all, because the central nervous system is immature. And so if I stop talking in front of you, then you will probably recognize that I'm having something wrong, and maybe some of you will say that I'm having a seizure. But if a baby does the same thing in the incubator, nobody will notice that. First of all, because of the immaturity of the central nervous system, because the baby doesn't talk, so it cannot stop talking. And the baby doesn't have a lot of function developed yet. So if these functions are impaired, a seizure is a discharge that goes into several regions in the brain and impair this region. And so if this function is not developed yet, you cannot see the impairment of the function. Because it's difficult to look at, as Linda was showing to you, for a baby that is in the NICU, we other 15 babies, and sometimes it's difficult to see with small changes or small abnormal movements, and also because my hand and my arm is big, but the arm and the hand of a baby is really small. It's difficult might be difficult to perform EEG in the neonatal period in the intensive care unit, especially for long-term monitoring. But I'm glad that some of you are doing this, and I think this should be implemented more and more. But the most important problem, and I think we should really go over that, is the lack of the close interaction between neonatologists, neurologists, and neurophysiologists. And having had the chance to work at the Bambino Gesù where we do that, and at UCSF, where we have a neonatal intensive care unit dedicated to neurological problem, I think that this is really the key to move forward and to work together. And when we say the word neonatal neurologist, this could be a neonatologist, this could be a child neurologist, she should be every person that takes care of the neonatal brain. So motor arrest, or so-called seizures with hypomotor features, this is what you can see and easily diagnose, as I was saying, for me or for any other older child. So if you look at this baby, there is no audio. So what we can say? We can say that this baby is having this repetitive and movements, and then he stops. and then he will start again. And in between, he cries, and then he stops crying. So at some point, he has a motor arrest. And if we look at the EEG, then we have this, you can see, oh, Jérôme, do you have your... Yes. If you have one.
I just got to the phone.
And so if you look at the EEG recording, so this is a full EEG. We have 4 leads on the left, 4 leads on the right, and then left to right. And then you see those are the muscle artifacts when the baby moves. Then there is these bilateral discharges of spikes, and then you see no artifacts because this is where the baby is still and doesn't move, and then you have the artifact again. So this discharge corresponds to the seizure, and if you look at the video EEG monitoring, then you see that this is exactly what happens. So the baby moves, and here you have all the muscle artifacts for the moving, and then immediately when the bilateral discharge will appear, the baby will stop. And this is a psychomotor, this is a motor arrest or hypomotor seizure. So this type of seizure can be quite difficult to diagnose in the newborn, and this is why it's difficult to talk about subclinical seizures. How many seizures are really subclinical, or how many seizures we call subclinical because we are not able, with our means, to recognize the clinical symptoms? And this is another baby, and I will show you probably some case that will overlap with Linda. So this is a well newborn that was born normal APGAR and 6 hours of life. Parents and the nurse noticed this movement. And I think that all of you will recognize this and say that this is what kind of seizures. So this is correctly defined as a focal clonic seizure. This seizure is quite long, and I won't show you the whole seizure, but was more than 10 minutes long. But even though it was quite prolonged, was limited to the left arm. So this is a clinical manifestation of a seizure, and why the EEG can be useful. So this is the full EEG, and you here have a discharge over the right central region. The seizure goes on. You see that the background is quite good. The rest of the background is quite good. And here you have the ictal discharge. And I will show you page after page, and you will recognize the ictal discharge, the repetitive spikes. Even though the seizure is prolonged, every page in a conventional EEG is 20 seconds. Even though the seizure is prolonged, it remains very much confined. So by looking at the EEG, we can tell that this is an acute focal event, that even though the seizure is prolonged, the rest of the background is spared, and so we might assume that this is a very small and focal stroke. See, the seizure, the discharge remains very nicely confined, and I think this is important because if we are in the middle of the night, the ultrasound of this baby was normal, do we need to run and get an MRI? It's very unlikely that this baby will have an hemorrhage because you see that this is very confined and small, and so I think we can wait for the MRI, and when we did the MRI the next day, this baby was having a very small stroke, and there was a very nice concordance between the EEG, the clinical manifestation, and the MRI. He had a very small stroke over the right central region, so exactly corresponding to the location of the seizure. But if you have this other baby, this is a baby that was cooled for hypoxic ischemia, and is undergoing, this is University of California, San Francisco, is undergoing a neurological exam. And he is having exactly the same type of manifestation that I showed you before. This is a focal clonic seizure. Even though the baby was undergoing a neurological exam, the seizure lasted through the exam and nobody noticed that. So is this a subclinical seizure? This is a clinical seizure that was unnoticed. So we should be very careful when we use the term of subclinical seizure. It is very possible that some, at least subclinical seizure, are clinical, but we don't catch the seizure. See? So these things happen, and nobody's perfect, and everybody has to learn. But this, I think, is very impressive. Why this happened? Because you need to take the time. First of all, never put yourself in front of the camera, because this will make the neurophysiologist really mad. But then these things happen because sometimes you have to take the chance and stare at the baby and stare at the bedsides and look at the baby. So, and this is the EEG of the baby, and you can see that here you have an ictal discharge, this time over the left central region, and the discharge is here on C3, so the left central region. Those are the artifacts due to the fact that this was going the neurological exam, the seizure goes on and is quite long and was not noticed. So what are the objectives of this lecture? I would like to help you recognize seizures in the newborn, both clinically and on the EEG side. Show you that it's important to evaluate the brain activity, especially in the critically ill baby, and the importance of continuous brain monitoring, and I do EEG. And maybe then we can think about changing the current clinical practice in most centers. What is the current clinical practice? What happens in most centers is that the neonate at risk, like hypoxic ischemia or a baby with meningitis, are visually monitored for clinical seizure. So we look at them and we check if there is any suspicion of seizure. We get a routine EEG, which is a 1 hour or half an hour EEG, or we start empiric treatment. Is 2 o'clock in the night, we just give some phenobarbital. So this approach that is very common presumes that most electrographic seizures will give rise to visually observable clinical manifestation. So what about this baby? This baby has hypoxic ischemic encephalopathy and is being cooled and is undergoing a heart ultrasound. What do you see? Any volunteer? There is nothing to see because this baby is doing nothing and is not moving. And this is her EEG. This baby had for 6 hours bilateral status epilepticus that was only captured with the EEG monitoring and never had a clinical manifestation. This is quite impressive. So why it is important to recognize and treat seizures, especially in this setting? First of all, because we want to be sure that we are not missing etiology that might need specific treatment, and I'm talking about metabolic disorder, hypoxic ischemic encephalopathy, maybe stroke, because many studies are now showing both in animals and in humans and newborn that uncontrolled or untreated seizure, at least they have a trend in worsened long-term outcome, and because anti-epileptic medication can have side effects. And both animal study has shown that you can have death of neurons with certain anti-epileptic medication, especially phenobarbital and benzodiazepine. And if we need to use it, we will use it, but you don't want to use it if it's not necessary. And this is the study that Linda De Vries showed you in detail, and they were newborn with HIE monitored with amplitude integrated EEG. And what they shown is that the severity of brain injury that was seen on MRI was associated with a longer duration of seizure, and we recently confirmed with conventional EEG at UCSF. So who are these babies? They don't have a clinical correlate with electrographic seizures. Unfortunately, they are the baby that are most sick. Baby with severe diffuse encephalopathies, baby who had, of course, neuromuscular blocking drugs, and baby who's received antiepileptic drugs. This is very, very, very important. Every time you give phenobarbital, even though you don't have AEG and you can only count on intermittent EEG, please get a control EEG at some point, because it's very frequent that you don't see anymore the clinical manifestation and somehow you lose your ability to recognize seizure, because this baby won't have any clinical manifestation anymore, but they might seize in their brain. So please, please ask for an EEG control if you don't have AEG or EEG monitoring. This is a difficult subject to talk about because this is the clinical neonatal seizure. Clinical seizure, this is a word that is very much used in the neonatology setting. Doesn't really exist very much in children and in adults. So clinical neonatal seizure, this is a work that has been done at UCSF, are independently associated with outcome, and here is another work from another group saying that they have no independent impact on neurodevelopmental outcome. But my goal is to talk about this word, so clinical seizure. What are clinical seizure? Clinical seizure are defined as paroxysmal event, means an event with an abrupt beginning and abrupt end that is presumed to be and treated as seizure based on the clinical observation. So what is this? What do you think? So what is this movement? Should we get an EEG? Should we treat? What should we do? Nothing. This is jitteriness. Exactly. So this is jitteriness, and if you want to be sure, you might want to constrain the baby or change the position, and the jitteriness will disappear. So what's the difference between jitteriness and seizures? The dominant movement in jitteriness is tremor, and tremor is a rhythmic oscillating movement by agonist and antagonist muscle around a fixed axis. So this is the movement, and the movement is equal in frequency in both directions. Clonic jerking is the main component of a clonic seizure, and it has two parts. It has a fast component followed by a slow component. So semiologically, they are completely different. And I will show you this baby boy, 10-week-old, ex-34-weeker, that was admitted with bronchiolitis and spent 3 weeks on ECMO. He was improving from cardiorespiratory standpoint and was weaning off morphine and benzodiazepine. And then the mother and nurse noted rhythmic twitching of the left hand, arm, and leg. Head ultrasound were normal. So what is this? Jitteriness. Jitteriness. But the fact is that the nurses were insisting, and we also should listen to nurses because they stand there all the time, and so they were saying, we are sure he had clonic jerks. And actually this baby had both jitteriness and so the jitteriness stops when you hold the hands of the baby, but you need to spend the time because this situation can be difficult, especially if you don't have EEG. And indeed, together with the jitteriness, this baby was having focal clonic seizure. And see the difference? The jitteriness could be stopped by simply holding the hands of the baby, but not only cannot be stopped, but the simply movement of the clonic jerking can lift the hand of the examiner up. So semiologically, they are completely different movements. So clonic seizure has a rapid flexion phase followed by a slower extensor movement, can involve any part of the body, face, arm, leg. You can have diaphragmatic clonic seizure. Is usually focal but can be multifocal. And multifocal clonic jerks are different than myoclonic jerks, and I will show you why.